Hello, hello, everybody, and happy Thursday Night Live. We are here with the incredible Dr. Lynn Gerner. Thank you so much for joining us today.
You're welcome.
I'm going to go ahead and introduce our speaker. Dr. Lynn Gerner is a graduate of Life Chiropractic College West in Hayward, California. And she has been in private practice since that time, focused on pediatric care and breastfeeding support. She earned her fellow in pediatrics in 2004, and she's a trained doula and earned her CLEC, which is Certified Lactation Educator Counselor, in 2021. She's currently earning her IBCLC, International Board Certified Lactation Consultant. She founded the Good Life Learning, a professional educational company, in 2019 to help spread the word about the benefit of the chiropractic adjustment in connection with feeding dysfunction and oral restrictions. She currently teaches privately as well as with the ICPA, International Chiropractic Pediatric Association, Life Chiropractic College West, Northwestern Chiropractic College, and Gold Lactation Learning. She is also currently conducting research with Dr. Shervin Yazdi on the benefits of bodywork for infants with ankylosing. Dr. Gerner is a wife, mother of 4 adult children, and lives in Davis, California with her family and rescue dogs. Beyond her professional work, her other passions are traveling the world and combining that with teaching and cycling whenever possible. Welcome to the Airway Circle stage. We're so happy to have you here. Would you like
Thank you.
to add anything to that wonderful bio?
The only thing I'm going to add is that you said that I graduated, but that was 20 years ago. So I'm open to saying that I'm an old person now. So I've been in practice for over 20 years, and that IBCLC is just waiting for an exam. I've done
Yay!
all of my hours, all of my coursework, and I just have to sit for the exam. So we're almost there.
Oh my goodness, that is wonderful. Well, if you're an Airway Circle member, you are watching this live and you have early access to these recordings. If you're not one yet, please join us. You help us support our directory that sends patients to you, straight to you from the directory. We have over 600 names globally and over 3,000 visits a month to our directory. So patients are trying to find you. It is free to join. Our webinars on Thursdays are free to watch. So invite your colleagues, invite your friends. We all need to keep learning together. Since the body is so complex, we know everything is connected and we can learn so much from each other. So thanks for being part of the Airway Circle Study Club. And here we are. We can go ahead and share our screen so we can start today's webinar. Another thing, as we're waiting for that, Airway Circle Retreat, save the date. It's going to be in Hilton Head Island, South Carolina, April 10th through April 12th. The speakers are incredible. I cannot wait to share with you guys. It's going to be a very small group. We're going to be talking about personal growth, business growth, and of course, airway. So make sure to apply. I'll leave the link in the comments. Apply to be one of the participants chosen to be there with us. It's going to be multidisciplinary. Thank you so much, Lynn. We can see everything.
Awesome. Okay. So I'm going to just go through these. You already went through all of that. Okay. So now I'm going to be going through a lot of this pretty quickly because I think the audience that we have here are already experts, and I don't have to belittle or belabor too many things. And it's hard to talk for an hour, or actually 45 minutes ideally. I'm used to talking, giving 12-hour seminars. So if I go through anything too quickly, please feel free to ask a question about it. So as everybody in this audience is very aware, over the last 15 to 20 years, there's been a huge increase in not only the diagnosis, but the treatment of ankylosing or tongue tie. It's a huge topic in the breastfeeding world. That's what I specialize in. And as I'll mention along the way, all of these same topics really relate to really any airway issues, but our topic today happens to be breastfeeding because that's what I love to do. But this slide is just meant to show that there's a lot of question about that too, that it's really hard to kind of know exactly what the rates are, what the increases have been, and it's under a lot of scrutiny right now. So Here is, I'm going to just go through very briefly a couple of articles that are getting a lot of attention right now. A lot of attention in my world. I teach extensively, mostly to chiropractors, to train them to do this type of work, to do this supportive body work. I get the opportunity to teach in other arenas sometimes, and I'm looking to do that more and more and more to spread this information. But here's a couple of articles that we are all very aware of and what is causing a lot of attention on this subject. If anybody's not aware, just a couple months ago in July of 2024, the American Academy of Pediatrics came out and gave a cautionary um, statement about diagnosing and the surgical treatment of ankyloglossia, of posterior tongue tie. And as you can see on this slide, it says mainly that there's just no uniform accepted diagnostic criteria. And that, as I highlighted here, there's no noted clear criteria for not only the diagnosis of ankyloglossia, but also they're finding that there's lacking a good evaluation of treatments, that it's very subjective. So I'm not saying this in any way as a criticism. I'm just bringing this to light because this is what is being read and what is being kind of talked about and what a concern is right now. This is a slide actually that I have to give credit for. Because I just finished my own IBCLC training through UC San Diego, which was an amazing program. And I stole this actually directly from that training. And as you can see here, the diagnosis of, or the description of a tongue tie is pretty vague. It's described as just when the lingual frenulum is either too short, too thick, or too tight. And what I'm going to quickly talk about today is the fact that there's a lot of different reasons for that, not just that genetically or that actual shortened frenulum. There are many other factors here. Okay. Here's another statement that came out a couple of years earlier. This is November or September, I think, of 2021. This was from the Academy of Breastfeeding Medicine. And I pulled this sentence out of there. They describe tongue tie as a functional diagnosis, which is actually a really important differentiation. Just like this slide says, this is absolutely talking about it also as a functional diagnosis versus a genetic one. And we're going to talk about that as I go here. Talking about functionally being too short, too thick, too tight. This statement also from the ABM talks about it as functional and saying that the presence of a sublingual frenulum alone, which is a common and normal anatomical structure, is not an indication necessarily for surgical intervention. And they talk about, I'm going to move this little box so that I can read this more. There we go. Obviously, we all know the decision to treat is one that requires a high level of clinical skill, judgment, and discernment. And they reiterate that there's an ongoing need for high quality research in these specific areas, including a clear definition of tongue tie in distinction to the normal sublingual frenulum. So what these two statements are talking about is the fact that there needs to be more of a definition between an actual genetically shortened frenulum and a functional tight frenulum, possibly because of other factors that we're going to be talking about. Okay. And just because I was recently teaching in Canada, I found this one. This is their position statement of the Canadian Pediatric Society. And of course, as you can see here, they say the same thing, that many infants with ankyloglossia, or at least I should say diagnosed with ankyloglossia, are asymptomatic and don't exhibit feeding problems. It's important to rule out other oral anomalies that may be causing breastfeeding difficulties. And that's my subject here. This is a game changer study. I don't have time to go through this very much at all. I'm just taking out little bitty tidbits of it. Anybody who's not familiar with this study should become familiar with it. It's mainly by a doctor named Dr. Nikki Mills. She's in Australia. And as you can see here, it's called Defining the Anatomy of the Neonatal Lingual Frenulum. And the main, I guess, point or take-home message from her long study is the fact that there's an extensive variation of normal tissue. She says here, there is an extensive variation between individuals in the appearance of the lingual frenulum, but an ambiguous relationship between frenulum appearance and functional limitation. An increasing number of infants are being diagnosed with ankyloglossia, with growing uncertainty regarding what can be considered normal lingual frenulum anatomy. Okay. So what she does in her study is she teases out and shows just different variations of what she considers to be normal tissue. So this is a just one example where she says here, obviously, I'm playing with my screen here. Oh, well, there are a number of variants. I can't see that sentence, but I should have memorized it by now. As you can see here, the range of lingual frenulum morphology is created by a variability on a number of factors. And some of the ones that she mentions are the height of the midline attachments, the length between these attachments, the relative gliding of the layers forming that fold. And she shows obviously those four different variations of what she feels to be are just normal tissue that, just like anything else in human anatomy, can present differently. Okay. The top paragraph here I find very, very interesting. And I'm sure, again, there's so many other statements out there talking about the previous way of classifying tongue ties being, class 1, 2, 3, 4, 4 being what might be called a hidden or submucosal tie. I studied or took a course with Dr. Bobby Gahary over on the West Coast here, who I hugely admire. He talks about the same thing about those classifications being probably not as accurate and being a little behind the time. But I'm going to read this one paragraph here. The lingual frenulum does not have a direct connection to the posterior tongue, also known as a tongue base, and is of embryologically different origin. I think that is a very important piece to tease out there. And the fact that I know I hear in my profession, I have heard many, many times in the lactation world, the assumption that if there is a very obvious anterior tie at the beginning of the tongue, that there is very likely just a continuation, a class, again, 1, 2, 3, 4, just being a continuation of the same thing, and that deep hidden or submucosal tie is one and the same. Well, Dr. Nikki Mills is talking about the fact that that's not true, that they are of embryologically different origin. So she, just like a few other people that I referred to, suggests that the term posterior tongue tie is anatomically incorrect nomenclature. A posterior tongue tie has an anatomical construct based on the misunderstanding that the lingual frenulum being a submucosal band and is abnormal. As such, she feels that the term posterior tie is potentially confusing and misleading. So again, there's a few other people that I'm aware of that also mentioned that, but I think the thing that kind of blew my mind with that statement is the point that she points out they're from embryologically different tissue. Okay. Here's another really amazing paper. This was actually done by a good friend of mine who I've taught with through the ICPA, Dr. Andrew Doro. He's a chiropractor in, O'Fallon, but I think that's the St. Louis area. And some of you listening probably are very familiar with Dr. Sharon Valone as well, who's also a chiropractor, a breastfeeding specialist who's done a lot of research. And again, very long title, but in just defining that title for in the layman's terms, they talk about how the effects of birth trauma on the structure of an infant can very much mimic a posterior tongue tie. And so they tie together a lot of these details about structure, function, and how it originates with birth trauma. This can be Googled. I really highly recommend that everybody reads this thoroughly. Again, just because of time, I'm just pulling out a few tidbits from this article. One study that they refer to, and I always hope that I'm pronouncing this correctly, Chaturvedi. I probably didn't say that right, but this particular study talked about the fact that getting the following birth presentations, which everybody can see on this list, are things that happen all the time, all too often, that all of these things are red flags and can cause and can look like, can affect, potentially impact the ability to suck, breathe, and swallow. So the following can be red flags that the infant has been subjected to mechanical birth stress, strain, or trauma to the head and neck and impact their ability to do all those things that they need to do in order to breastfeed. And again, I'm not going to read the list, but we can see that all of those things on there are very common in our, in our consultations and in the birth histories that we talk about with our patients. This is really interesting, again, pulled out from this paper. So what Dr. Doro and Dr. Vallone have done is to put into actual measurable forces, one in newtons, one in pounds of pressure, from a normal, like considered non-traumatic birth to all the way up to, using forceps vacuum and ranges of traction with that. So from a considered normal birth to a one that would be considered more traumatic. And as you can see here, I'm used to using pounds, so I'm going to look down here at the bottom, but that normal birth is measured at about 29 pounds per pressure, all the way up to the highest that was measured was almost 70 pounds per pressure, okay, on this newborn's cartilaginous, very delicate little neck and cranium. Well, because I'm a science geek and I teach a lot, when I read that, I instantly thought, well, how does that compare to a car accident? So I found this study that was done back in 2018. And according to this particular group, they found that the amount of force that was needed to create a shearing force in the cervical spine, a significant injury, and remember, this is on adult subjects, was anywhere from 30 to 56 pounds. Well, how does that compare with the birth? You see where I'm going with this. Birth trauma, even with a birth that is considered to be, non-traumatic, puts an extreme amount of pressure on that delicate little infant. Okay. So here's another little tidbit that this particular just part that I pulled out, partially also, he also refers to Dr. Nikki Mills' study. And he says it's critical to differentially diagnose the reasons for breastfeeding difficulties. A biomechanical injury to the head and neck should not be confused with the posterior tongue tie or any other anatomical restriction of the oral structures by ligamentous structure, meaning that the forces on that infant cranium and neck should not be, I guess what I should fully say is the effects of that injury, the breastfeeding challenges from that strain shouldn't be confused with the posterior tongue tie. Okay. So, and another one that I'm highlighting here, which I'll get to in a moment, which I thought was really interesting too, talking specifically about structure. One example of this is the hyoid bone, that when restricted by a nuchal cord or the torsion of the head and the upper cervical spine through birth, can result in a change in the muscular action of those muscles of the floor of the mouth. Now, we all know that the tongue is anchored into the hyoid bone. So the muscular actions we're talking about are the tongue muscles, the neck and the tongue, as well as the muscles that influence the range of motion at that junction, which is needed for proper nursing as well. The position and range of extension and elevation of the tongue can be reduced as a result. So very interesting. He is directly connecting the dots with part of the structure, the cranium, the hyoid, the upper cervical spine. So I'm going to dive into that a little bit further. And it's going to be pretty quick because we don't have a ton of time. But let's take a look at that. I love that picture. Very clear picture of a little diamond-shaped tongue. This little guy, I would say, even though I'm clear that I don't diagnose tongue ties, that's not my expertise or my scope, I can say he probably has an anterior tie there. Now, the very simple message on this slide is just the fact that just like any other muscle group of the body, the tongue muscles all have origin and insertion points. They all start and end on the structure. So the main points of anatomy, and I don't think that my little arrow is working on these presentations, but I have this pointed out. So a main attachment site, you look at the upper right side of that picture on the right, is the styloid process. That's a little spiky guy on the side of what's called the temporal bone, okay? And there's a number of tongue muscles that are attached there. There are, most of them insert into the hyoid, which sits right in front of C3 in the upper cervical spine. And then there's quite a few that insert into the interior of the mandible. So once again, take home message, if any of those structures are misaligned through the birth process, then the muscles of the tongue, again, like any other muscle in the body, become pulled and strained and just can't function properly. This slide's a little whimsical, but it points out this same thing, that even if we just look at head shape, and that's something that I have the huge honor of working pretty closely with Dr. Shervin Yazdi, who is a dentist release provider in the Bay Area. And we talk about head shape all the time. As you can see in this middle picture in the bottom, this would be what we call an extension, meaning the cranium has extended out. Layman terms, sometimes that's called a cone head. We look at the little baby over on the far left, you can see that whole global pattern. You can just see the torsion and the tension in that little body, the whole body there. Over on the far right, we have what's called a flexion pattern, where instead of being elongated, the body through the birth process can compress that head. And again, without going on too long about all the individual points of anatomy, I think most of us can see the point here that all of those, again, insertion points of the tongue that I talked about right here are going to be affected by these global patterns. The jaw, the palate, the hyoid, and all those attachment sites are going to be affected in a negative way. We all talk about the latch, again, almost being a IBCLC. That's a huge topic. We all need a great latch for the babies to adequately transfer and not take in too much air and to not cause nipple damage and pain, yada, yada. Well, guess what? Again, through that stress, strain, and trauma, that 29 to 69 pounds per pressure that happens during the birth process, guess what? Those bones that make up the jaw often get well, I'm using all of these words, these hand signals, because in my world, we're trained and we're used to the different ways that these bones move. But as you can see in the diagram on the left, they move in all sorts of different ways. In kind of a circular motion, they move like this. And again, just those stresses of trauma of birth can very easily misalign these and cause the baby to have a really difficult time to have a proper latch. This is a really fun one. Okay. The palate shape has everything to do also with the structure. Now, most of us know that the palate shape starts in utero, and ideally we have that nice, gentle curve because of the baby's ability to use its tongue to press up on the palate. But the abnormal presentations we have of the palate, like a super high bubble palate, has everything to do with structure. If we look over here at the far right, we see a kind of upside down, like a view of this way in the interior of the cranium. You see where I've pointed out the vomer. Well, in that, what I want to point out here is also what's called the sphenobasilar joint. I have my little sphenoid here. I have a little occiput here, and they meet in the middle like this in the cranium. They meet. And guess what? This is a bendy joint in the infant. It's a partially movable bendy joint, okay? Because it's for protection. If it didn't bend, then there'd be a lot more just a lot more pathological damage to that little cranium. So as if we look at that, you got to remember that little baby that has the extended cranium, the cone head, as it comes out, then this joint, which is right here, I don't know if you can see my arrow, but between the occiput and the sphenoid, right here, it flattens out. And because of where it sits, this is the sphenoid wing. If we're looking over at the far left, you can see in the middle here, I've labeled that. The palatine bone sits basically right on top and in front of that joint. So it could absolutely always, as this flattens down, it flips up. If this is that sphenobasilar joint in the interior of the cranium, and this little head is an extension, it's done this, and palate is right here. Look at my classes, I'll explain that in more, but it's really fun when you understand it. Okay, one more thing, I know I'm probably running out of time. The other thing that we can't forget is the nerve input to the tongue and to basically, it's a lot of other things as well. But look at where the hypoglossal nerve lives. It lives actually inside. There's a canal that looks like it was drilled between the two occipital condyles. If we're looking at my occiput, it's about right on either side right here. Okay. And again, take home message. This occiput is in 4 pieces in an infant. It's joined by cartilage. It's very bendy. It has room to kind of give a little bit like this. And stress, strain, trauma, torticollis, head tilt, you can just see the tension on that hypoglossal nerve that therefore can also produce a weak tongue just because it doesn't have the proper nerve flow. I'm not going to read through this. I'm a geek. I used to actually be a graphic designer before I became a chiropractor. I love charts. Take a look at this, screenshot this, that's fine. It gives you a more kind of brainiac scientific reason for all of these things that are important in the nursing function of the baby and what can go wrong on a biomechanical level and also a neurological level. Okay. Now, one thing that I want to say, I'm almost done, but really quickly, is that I always teach all of the chiropractors that I work with that timing is super important with this. I very much value and am so appreciative of the release providers and all of the other therapists that I work with. We have to work as a team, and I need the body workers, the chiropractors that I teach to know that we have a very short window of time in order to work our magic, so to speak, in order to work on the structure, in order to open up all of those pathways that I just talked about. So there is a very small window of time, and we absolutely need to be collaborating with each other to make sure that breastfeeding relationship is saved and that we are giving the best care as possible. There is always in a non-chiropractic group, which I understand I'm talking to a lot of non-chiropractors here, there is often a misunderstanding of what exactly a chiropractic adjustment is to an infant. This is, again, a very long study. I'm not even going to go through it. Please look it up and please be familiar with it. This is just something that I pulled out of it. Also measuring in newtons the amount of pressure in a newborn chiropractic adjustment. And it is absolutely incredibly gentle and safe, and actually has been measured to be one of the safest forms of care that there is for these newborns. Only 0.224 pounds of pressure per second. It's very similar to cranial sacral work. I just describe it as being a little more specific in certain directions. It's about the amount of pressure that you put on your eyeball. So I'm always careful to let people know that there's absolutely no snappy poppy. If there is, you should run out of that office and you should report that chiropractor, because that is not what pediatric adjustments are about. And this is the last slide, I promise. Please refer to a qualified chiropractor, okay? And I'm the first to say that. Here's what to look for when you're referring for body work, for this specific type of work, to help balance the structure, to open up those pathways, to help with feeding function. Obviously, an experienced doctor. Also, this is the most important one, specifically trained in pediatric cranial sacral work, okay? One chiropractor is not like another. Just like a podiatrist, you shouldn't have open heart surgery from a podiatrist, okay? We're specially trained in certain ways. Good places for that training is through the ICPA, whom I teach with. Upledger, I'm sure all of you have heard of Upledger, another amazing organization. I'm sure there are other ones, okay? The visit should take longer. If your chiropractor says it's like a 3 to 5 minute visit, likely not doing what they're supposed to be doing. It should be a very precise care plan that includes collaboration with other professionals. And as you can see here, the ICPA for Kids, the website, is a great place to look somebody up in your area who has been specifically trained. And if you want to get a hold of me, if you'd like me to speak for your organization or check out any of my trainings, that's how you could take a look at me, and I am done. Hard to say in the short period of time.
Yeah, stay there. Keep that screen because I'm going to take a screenshot and we can post it
Okay.
on Airway Circle.
And anybody I'm in Davis, which is near Sacramento, so I am very much in active practice. Would love to see your babies.
That is wonderful. My one of my best friends, Tamara, she's a myofunctional therapist in San Diego. And you mentioned San Diego earlier. So how exciting. You're welcome to stop sharing your screen.
Okay.
We'll do a few questions. What a wonderful presentation. Thank you so much. It is mind-blowing to see all these cranial bones and these cranial nerves and, so many things that we miss. Unless we talk to other professionals, unless we get extra training to be able to recognize all these things. So thank you so much for such a thoughtful and thorough presentation. At what point do the patients come to you in their breastfeeding journey? When are you seeing them?
Oh, at all different.
Mhm.
Ideally, I see them as soon as possible after birth, and that is actually very common. I would say, if I get the pleasure of taking care of mama while she's pregnant, that happens sometimes, then
Mhm.
it's sooner than later. Um, Oftentimes I see them in about a month after they have just been struggling, and somebody has sent them to me. The earlier the better. That's the ideal answer. The earlier the better. It is ideal if there has been a tie diagnosed, that they have some body work, foundational care prior to the releases. That's ideal. And then it's ideal to have some follow-up care afterwards. So they're all different ages, but the sooner the better. So that, all of those things that I talked about in that small window, the learned habits of feeding, the challenges with mom supply, all of those things, that they don't become an issue.
Very good. Do you notice any specific growth patterns with these little babies or whenever they're born, what you're feeling for in there with babies that were breached or babies that were, second question, babies that were C-section versus natural birth?
Oh, absolutely. I mean, those both come with very unique presentations. And let's not forget maybe what position they were in utero. It doesn't even start with the birth process. Lots of times that baby was in a very compromised position in utero. And so just like the little one that I showed, like with the whole global pattern like this, that very likely started before they even tried to be
Mhm.
born. And what I see afterwards, again, if that foundation hasn't been addressed, is that those little ones just have to adapt to that position as they develop. So I often get the question, well, what happens if they don't get those things worked out? What happens is that their body has to adapt to all those things. So they might be crawling differently. They might be learning their environment differently. There's so many things neurologically that happen.
How about those babies that are just born and the parents are so proud that they're already lifting their head up and they are super, super tight and tense, but they are looking at it as a positive thing? What do you usually see with those babies that are super tense?
Well, tension is a sign that there is something going on, you know. I'm sure that in the room we probably have some people trained with upledger cranial sacral therapists. So, looking at even the dural system, the dura mater or the continues through the cranium and is attached at the sacrum. So again, when we have those really tight babies,
Mhm.
very likely that whole dural system, including the CSF flow, is being affected. So it's a telltale sign for sure.
Can these moms who already have, most of moms already have airway issues, especially during pregnancy, it becomes a little bit harder to breathe. Your hormones can impact your, nasal obstruction and all these things. Can these moms' airway issues impact the way that they're going to grow these babies?
Oh, that's a good question. I mean, I would be hesitant to say no because in my, just 20 years of practice, I think that everything is connected, but I would have to say that that's not really my expertise.
Hmm.
But I can absolutely kind of see intellectually why that would happen. A different oxygen level,
Hmm.
having to compensate in their rib cage. I can think of all those things. So yeah, it makes sense that it would.
What happens if a baby gets a release without any prior work and without any work afterwards? What are the detriments of having a baby who is not properly aligned with everything flowing correctly and without too much body tension for them to just go get a release done?
So I think the most prudent answer would be it varies because no body is the same. So, I can conceivably say a baby that had very little trauma, was in a perfect position, has very little structural issues, they might do just fine.
Hmm.
Those aren't the babies that I tend to see.
Hmm.
So I can confidently say that a large majority, either through birth position, birth trauma, um, just really need to have those things worked on. And I guess the most precise answer would be kind of what I alluded to before is that if those things aren't working, well, there's a couple of things. A, perhaps the feeding doesn't get much better, or it doesn't get as much. That's not proper English. I would say as much better as it should, but you know what I'm trying to say.
Yeah,
I actually
100%. I'm from
taught to the
Brazil, so.
yeah, I taught to the Royal Chiropractic College in London last week, and I was very nervous about my California lingo. Anyway, you're not going to get the best results, basically.
Hmm.
You might have some improvement, some range of motion, but, the jaw hasn't been worked on for that latch, and the palate hasn't been worked on, in order to get a better seal, all of those things. But then beyond that, again, that baby has to learn different ways of maneuvering through the world, and that can, and studies have shown that it does affect their neurological development long term.
Wow. Are there any other issues that may mimic a tongue tie in terms of feeding for a baby?
Well, and again, I think that goes back to what do we define a tongue tie as? So when I was first getting immersed in this topic in practice, like about 10 years ago, I was always thinking, okay, we're trying to differentiate between a genetically short frenulum, and and not. Well, I think now more so like it's a functional diagnosis. So
Mm-hmm.
I don't think most people are trying to differentiate. They're just seeing if it's a tight frenulum, then we do what's in our scope to do. So, um, any alignment issue that either tractions the tongue muscles or makes the tongue muscles weaker, i.e., the nerve interference that I talked about, can absolutely mimic a tongue tie.
Very, very good. How is your post-op frenectomy care? Do you also do stretches? Do you do any manual therapy for these
Mhm.
babies?
Mhm. Yeah. Once again, it depends on the person as far as the amount of care. Some babies need more, some need less. But yes, I mean, included in both pre and post frenotomy care, I definitely do some intraoral work, working on, like say the pterygoid muscles, the cheek muscles, working on the palate, both from interior and exterior. Um, if the baby has recently had a release, I'm not going to go like down under obviously I'm going to avoid certain areas for a while because they're sore and I don't want them to become averse to anything in their mouth. But yes, like uh, a good chiropractor, a good body worker should be able to do some intraoral work.
Perfect. The doctor that you are collaborating with on some research, um, I wanted to ask specifically about tongue stretches after the frenectomy. I am part of a Brazilian group of myofunctional therapists, and the discussion that we had yesterday is that they are not showing on research that these tongue stretches are actually beneficial. However, we do know that these release providers that are the biggest ones in the US that are doing this every single day recommend stretches. And we do notice um, most babies or people who get tongue tie releases, if they don't have the proper work, we do notice more rate of reattachment or
Yeah.
symptoms not completely going away. From your experience and the research that you guys are conducting, how do you feel about that?
Well, again, I think partially I'm going to defer to the release provider for that because as far as the stretches that they recommend after the surgery, I think that that's more their scope. However, I have to admit that I have also been curious about that because, as you're
Mm-hmm.
aware, not too many years ago, the stretches were much more intense and frequent. And, I was always taught like if you don't do them, it's going to reattach.
Yes.
And so honestly, like maybe I need to watch another like Thursday Night Live on somebody to explain that because I'm assuming that I mean there's probably twofold reason why they're less invasive or easier, not as intense anymore. I would say one um for what's the word? Just having the parents do it. I think it was
Mm-hmm.
probably hard to get the parents to go ahead and do every 4 hours completely sweeping under the tongue. I have
Yeah.
IBCLCs that I have worked with that would go under and break up that tissue, and it was traumatizing for everybody. So I
Mm-hmm.
can see that if you get a greater, what's the word I'm looking for? If they'll actually do it, this is my California lingo, um, patient there's a word there, but if the parents will actually do the easy one,
Compliance, adherence.
compliance, yes, thank
Mhm.
you. Thank you for, Laura, yes. If you get a better patient compliance, then okay, maybe it's great to do less. And that might be, again, where the structural work, the therapy comes in afterwards to support that.
Mhm.
So I would have to defer to somebody else as far as if they're getting as good of results or if the
Mhm.
reattachment rates are increasing or not.
Awesome. Thank you for answering that. Yes, I've been curious about it also. And if anybody listening to this has some input, please let us know right in the comments below or make a post on Airway Circle Professionals on Facebook. And we would love to have a discussion about this. Thank you. Thank you. Thank you.
Welcome.
Thank you, Dr. Lynn, so much for spending an hour with us today. This has been wonderful. I know so many patients and professionals are going to benefit from you sharing this with us. I'll make sure to share your contact info and your classes on our Facebook group. If you guys are not in the Facebook group yet, please join us. It is free for everybody to join. We have 3,100 professionals there yet from all over the world, multidisciplinary, and we're always sharing the Thursday Night Lives. We share research, we ask questions, we try to find professionals to collaborate with. So it's a great community that we have built and would love to have you be a part of it. So thank you so much. Any last words?
Thank you for having me. I hope to do, well, I guess my last words is that I really am hoping to be able to speak to more professionals outside of my particular scope. I love teaching, and I'd really like to get the information out there so that we can all collaborate a lot more together.
Well, on our social media altogether, we reach from 60 to over 100,000 people every single month. So we hope that more and more people are going to hear your word and we'll be able to reach out to you.
Great. Thank you very much.
Thank you so much, everybody. Have a wonderful night. Bye bye.